Well, thank you, Chair People. What I'd like to talk about today is some work we've been doing applying a novel multi-channel fibre optic pressure transducer to investigate the pressure distribution along the urethra in men and women. So the basis for this work is the understanding that continence, particularly in men, in our recent work has been shown to be related to an interaction between multiple different striated muscles that have an impact on the urethra. So we have the smooth muscle, which can affect the bladder, neck and urethra. We also have the levator ani, or puborectalis, striated urethral sphincter and bulbocavernosus, which all apply pressure at different regions along the urethra. Now, conventional pressure recording techniques with a transducer in the bladder and one in the urethra don't have the capacity to give a differential investigation of the multiple regions of pressure increase. So what we've done is to apply a new fibre optic pressure transducer, which enables the location of sensors at 1 centimetre intervals along a catheter that can be placed within the urethra. And what you can see is that when the catheter is in situ, we can separately investigate pressures related to each of the different muscles that surround the urethra. So we've done a proof of concept study in one male and one female. What I'm showing you in this slide on the left is the transabdominal ultrasound images showing the catheter with the tip located within the bladder. And on the right-hand side, I'm showing you the transperineal ultrasound images of a male at the top and a female at the bottom. And the red line indicates the path of the catheter. And what we expect is that in the male, there'll be a distribution of pressure related to 3 different muscles. And in the female, there'll be at least 2 regions of pressure increase related to different muscle contributions to continence. So we assessed the face validity of the pressure recordings by evaluating the relationship between displacements related to contraction of muscle that could be measured from ultrasound imaging against the pressures recorded in a range of tasks. And what I'm showing you here is the recordings from this multi-transducer catheter from a male participant at the top, female participant at the bottom. And what you can see is traces related to each of the different muscles. Now, there's a couple of features that are interesting in this proof of concept study. So in the male participant at the top, you can see this sequential activation from a distal to proximal order of pressure increase related to these different muscles. And in the female participant, a more synchronous onset. The same thing occurred with a ramped pressure increase. So this is a person generating intra-abdominal pressure in a ramped manner without concentrating on the pelvic floor. And we see the same sequence difference between genders. What you can also see is that there is the peak pressure occurs at different times in the distal and the proximal regions of the catheter. And what that highlights is that there is a differential impact of pressure from different muscles at different sites along the urethra. This is showing you a surface plot that gives us an indication of the pressure distribution along the transducer over time. At the top is the male, bottom the female. And what you can see again is the different patterns of pressure change that occur related to different muscles that have an impact on constriction of the urethra. So what we've shown is that we can successfully record pressure along the urethra. We've provided face validity by comparing transperineal ultrasound imaging methods with the pressure changes. The pressure changes did differ along the urethra, suggesting a non-uniform pressure change related to activation of different muscles. And there is preliminary data that there may be some sex differences in how this distribution of pressure occurs. And I'll finish there by acknowledging the people who gave financial support for this work.
Thank you very much for this very interesting lecture. Questions, please? Yes, please.
Lawrence Stewart, Edinburgh, Scotland. There's an initial problem with this because catheters in the urethra, which you keep static, are likely to move. How did you stop it moving?
So with the preliminary catheter, we didn't try to stop the movement, but what we've been able to do is to evaluate the location by looking at the tip of the transducer within the bladder so we can see if there's movement. And we can also track the pressure change. So we can actually see the bladder pressure and we can observe over time whether the bladder pressure location sensors are different. So we've been able to, with each contraction type, evaluate where the most likely location of the transducer is. The new version of the catheter, which is the development from this, is then to have a stabilisation mechanism to enable the transducer to stay in a consistent location. And we have 2 ways of doing that we've used for EMG electrodes in the past.
Someone did stitch the catheters in the past, which is never very clinically acceptable.
Mm-hmm. What we've done for our EMG electrode is to use suction. So we can suction the electrode onto the mucosa, and that keeps it in place extremely confidently. And that's what we're going to try next for this.
Thank you.
Hi, Jennifer Kruger from New Zealand. Really nice study. I just was curious, were you doing your ultrasound imaging during the voiding? And if so, how visible was the catheter during that time? Could you match that anatomical location?
We haven't done it during voiding, but we
Okay.
have done it during contractions.
Okay, so this was just during a contraction.
So a whole sequence of different contraction types. The catheter is actually designed so that it can be voided around.
Yeah.
So that is one of the next things that we'll test.
Thank
Yes, please.
David Budgett, University of Auckland. Beautiful catheter, beautiful sensor. It has a pressure window. The pressure windows are on one side. If you were to rotate the catheter, could that change the pressure recordings in the urethra?
It probably will, because the striated urethral sphincter, for example, only is a horseshoe-shaped muscle, so it is actually on the anterior and lateral sides. So we have done experiments where there's been gentle rotation of the catheter, and so there is some difference in pressure, which highlights the fact that we need to stabilise the electrode, the catheter within the urethra, which is the next step.
So there's an intended orientation which you're
Yeah.
intentionally making.
The orientation that would be most useful would be to have an anterior orientation.
Thank you very much. So our next speaker is Dr. Taylor from Imperial College London, and she'll be discussing perimeter and digital examination variation with the levator ani hiatus size.
Good morning and thank you. My disclosures. So the ability of a woman to carry out a pelvic floor muscle contraction can be assessed using digital vaginal examination, and most of us would use the modified Oxford scale score between 0 and 5. In addition, or alternatively, vaginal manometry using a perineometer can provide a measured value of the muscle contraction strength and is thought to be an objective assessment. The aim of our study was to assess manometry readings of a simulated pelvic floor muscle contraction using a small and a large model levator hiatus, and the size of our models was determined by previously described transperineal ultrasound measurements of the levator hiatus. We hypothesized that the simulated pelvic floor muscle contraction in a large model would produce a lower vaginal manometry pressure compared with a small model with equal simulated muscle contraction strength. So we had a simple model. We used a neonatal blood pressure cuff to represent the pelvic floor, and inflating the cuff to 7 set pressure points simulated a pelvic floor muscle contraction. Digital examination was then carried out by 3 experienced examiners at 2 different time points, and each examination was assigned a modified Oxford scale score. The test was then repeated using a perineometer and was carried out twice for each model and with increasing baseline perineometer pressures. So the results of our digital findings, so there was a positive correlation between the increasing cuff pressure seen along the bottom of the graphs and the modified Oxford scale score on the y-axis. This is the small model on the left and the large model on the right, and all the examiner findings are present. There was no significant difference between the Oxford score assigned for each simulated muscle contraction strength. We have a similar graph for the manometry results, so again the cuff pressure along the bottom and the perineometer measurements on the y-axis. The results show that for both the small model and the large model, the perineometer pressure readings increased with increasing cuff pressure. However, what's obvious is for the smaller model, the perineometer readings were significantly higher than those for the larger model. So in conclusion, perineometer measurements show a larger rise from baseline in a small model compared with the large model. In contrast, using digital examination, the modified Oxford scale scores increase similarly for both model sizes. So overall, the study is demonstrating that perhaps perineometer readings can be affected by the natural variations in levator hiatus size and pelvic floor muscle contraction strength. And this would make it difficult to compare the measurements between patients, but also whilst assessing pelvic floor muscle contraction improvement, the perineometer cannot be interpreted as well unless we know levator hiatus size. Thank you.
Questions, please. I have just one question. This hiatus size, how did that correlate to the clinical situation?
So the sizes that we used was just taken from a study of nulliparous women who were having ultrasound measurements taken, and it was an ethnicity-based study. We just used a model based on those sizes. So a static representing a static examination and just a pelvic floor muscle contraction.
Did your model take into consideration the tissue interposed between the finger and the muscle, and also your device and the muscle?
So
in the clinical situation, you'll have some tissue there.
So the neonatal blood pressure cuff would represent our pelvic floor, and to carry out the examination, the cuff was completely deflated. You'd start the examination and we'd increase the pressure accordingly, and it was to set pressure points to represent whatever strength contraction we were testing.
Thank you very much. And